Welcome to the Professional Dog Trainers Australia podcast, Dog Training Matters. Dive into effective training and behaviour modification techniques, share expert insights, debate hot topics, and discuss how to build strong, positive relationships with our canine companions. Whether you're a seasoned trainer or just starting out, join us as we champion methods that respect both dogs and their human partners. Let's embark on this journey together to elevate the world of dog training, because dog training matters.
Hi guys, and thank you for joining us today at the Professional Dog Trainers Australia podcast, Dog Training Matters. I'm joined today by a couple of hosts. We have Steve, who is the PDTA president, and also Jacqui, who is a PDTA committee member. So hi guys, how you going?
Yeah, good, thanks.
Fantastic. And of course, we have our special guest today. We have Dr. Michelle Rassool. I hope I've pronounced that correctly, Michelle. Dr. Michelle Rassool, who is a behaviour vet here in Melbourne. And she has very kindly agreed to join us today for the podcast. And we have titled that podcast, Integrations Between Medicine and Training. And basically, it's going to be a discussion about having a chat about medication and training and where the two are going to complement each other, where they don't maybe, and maybe asking Michelle some of the sticky questions that we trainers have, and just getting a better understanding of the medications, how they work, how they can work when integrated into a training program. So thank you, Michelle, for joining us.
Thanks so much for having me. I'm really excited to be here.
Absolutely. And what we will start off, I think, just let the audience know a little bit about you and what you do, about the work that you do and your experience as a vet.
Yeah, so I work between two major areas. I work as a general practice vet, so seeing a lot of routine cases, surgery, medicine, all that kind of stuff. And in the last several years, I've also been doing a lot more behaviour work. So last year I got an additional qualification in behaviour, and I work a couple of days a week from a dedicated behaviour service here in Melbourne.
Beautiful. And the reason we asked Michelle, there's a number of vets out there and they're all very good. But the reason I'm a big fan of Michelle, because I've been sort of working, with Michelle when I refer clients to her. So if I come across a dog that I think really needs some medical intervention, I will refer the client onto Michelle. And the beauty of Michelle, I'm not sure if there are other vets that do this, but she works fairly closely with us trainers. She's probably the only vet that I know that if I've referred a client to her, Michelle will actually CC me in the email that she sends on to the clients with regards to the medications and why and what. She attaches the handout that she provides with regards to, how behaviour works and all that sort of stuff, but also complementing the training that, we might do and might discuss. And I think the beauty of that is that when I read that, I can then go to my client and say, okay, well, I know what Dr. Michelle has prescribed. This is what she's recommended. And now I can put together my training program, which is going to complement what Michelle has done. And there's been one or two cases where we've gone back and forward, with feedback and updates and things like that. And I think that's fantastic to be able to do that. I don't know of too many vets that do that, especially not the actual, vet behaviourists. But I think it's really refreshing, Michelle, that you do that with the trainers here in Melbourne that I know of anyway. If you do it with other trainers interstate, then I'm not sure about that. But, yeah, I reckon it's fantastic.
Yeah, thank you so much. When I created my service, I knew I wanted to have a real integration and almost like an allied health feel to the way that I work. While I would love to do a heap of behaviour modification with all of my clients, often a lot of the time that we spend together is focused on, understanding the behaviour, talking about motivations, mental health issues. And while we might plot out what a behaviour modification plan looks like, often we only have 5 or 10 minutes at the end of a session to actually implement stuff. So I rely on a large network of trainers throughout the state, and actually some interstate as well. It's a bit harder, but with technology, it becomes easier, where, my client and I might formulate or fine tune a behaviour modification plan, but the action of that is usually carried out alongside a trainer. And I also find it very valuable to get expert, opinions on what's happening with my dog the client and their dog, it's very valuable to me as well.
Michelle, do you find that many trainers do reach out to you? Obviously, more in Victoria, but do you find that they do reach out to you and refer people to you often, or is it a last resort or a first resort? What do you normally find?
It's a really great question. It's often a mixed bag. At the end of the year, I try to look back on the year that's passed and assess where folks have come from, just to understand the needs that the clients that come to me have. And there's a bulk, I would say there's a good proportion where someone reaches out to a trainer and the trainer looks at the problem list of that dog, and it might be really broad, practice for a really long time, or very complex or severe, and they may actually send me that dog and client first. I think that's really valuable because it gives me a chance to understand if there are medical issues that are contributing. So we know that in over 50% of anxiety cases, and I think over around 80% of aggression cases, there's often some medical underlying thing that we need to go and adjust, which is maybe contributing to the behavior. So often I meet people at the first part of their journey, and that's not necessarily for behavior medication. And then there's a good proportion of clients that I receive after they've worked with a trainer for anywhere between one session to, several months or years, where folks are maybe starting to hit a plateau and it can feel hard to move into the next step. And so I'll often receive people there. And I meet a huge number of people that have a personal ethos about where medical intervention sits. And for some people, that's a very early in their journey. For some people, it is a complete last resort, and that can often be a challenge. But yeah, it's very varied. But I would say as my business has grown and the work I've done has grown, I'm getting a lot more folks that find me just through internet or social media. But I absolutely have a large proportion of my clientele coming from trainer referral, which is so valuable to me.
I think there's some good points that you made there, Michelle, and a couple I'd like to touch on would be, firstly, is I think it's that the referring specialist, so if you went to a doctor, a GP, and he said you need to go and see a throat specialist, you'll go there and they will obviously include the referring doctor in that information too, so we know it's going back and forth and close that loop. And I think it's really important that vets do that too. The vets that I work with here are very good at discussing things with me, and sometimes they'll see the dog, they'll ring up and go, which part of this do you think there's training, and do you think there's a medical component, what do you think, I saw this. So I think that's important. And that's something else that I probably want to mention is that a long time ago, it was quite normal when, I guess, someone had a problem with their dog, and maybe the problem has come up quite recently. So the dog was completely fine for a few years, then all of a sudden he decides that he's a bit grumbly if someone touches him on the head or he's had a snack or something. And you might read someone recommending that they get a vet check. And I would go, yes, that's a very good idea, because he could have an ear infection or something going on there that's motivating him to behave that way. But in more recent times, we have found that when people go to just a general vet and say that my dog has got some behaviour problem, the vet may not be experienced in dealing with these things and either jump straight into medication or make a diagnosis outside of their experience and not refer to trainers and maybe make it more difficult for us long term. So nowadays it's more of a situation where I see a dog come to me and I will try and assess the dog overall to make sure I can't see anything that's causing him pain or dramas or anything like that. If I do, of course, I'm going to refer him to a vet, but sending him to the vet first, although I think it probably has its merits, it can actually be counterproductive to progress with that dog sometimes.
Yeah, I think it's important that clients feel empowered to advocate for what they're needing when they go to a vet clinic. And in the case that you described, which I'm guessing is probably just really a made-up one, where a dog suddenly is showing signs of aggression, I guess my counter as someone that works in both the behaviour and the veterinary space is I'm always looking for pain in those dogs. And it can be subtle stuff. Neck and spinal pain can be particularly challenging to diagnose. And in my hands, someone that comes to me with a sudden onset of aggression, even if I can't localize pain, I absolutely almost always do a pain relief trial for those dogs. And so I guess my counter to that thought would be, I agree that for some folks, if they kind of turn up at the vet and say, look, my dog's biting and I'm not sure what to do, can you help me? Then they may end up going through some behavior treatment with a vet that maybe feels a bit out of their depth. I can't know what other people are experiencing, but in my hands and in the clinic and the teams that I work with, typically what we do is we look for pain, we assess for pain, and we often do some medical workup. I would say, to me, I would perceive it unlikely that behaviour medicines are directly where most people would go for, but I can completely understand that may be some people's experience. I'm not sure it's a great way to practice medicine, but by the same token, I'm really conscious that in the GP setting, I often meet people that are not seeing me because I have experience in behaviour, but are really adamant that they want to explore behaviour medicines. So I can sort of see both sides of that experience.
Yeah,
Sorry.
it's very common in our industry that, dogs go to let's say a GP vet and say that the dog's got a behaviour problem. The dog's getting weighed and medicated with fluoxetine or trazodone or catapress on that one stage. There's no bloods, no nothing. Here we go, and they mess around with doses after that. And this can be a very, very common thing. In fact, I'm seeing lots and lots of dogs like that.
Yeah, I certainly think it's an interesting changing landscape in veterinary and human health, where I guess the understanding or presence of mental health is much more in the forefront of people's mind, and sometimes we can start to see it everywhere. And I guess one thing I keep coming back to in the work that I do and the work that other people do is that I think good work tends to be good and sort of average work tends to be average. And whether that's trainers or vets, is that if folks are working outside of their kind of comfort zone, then it can often end up being average work. And I'll probably put my hand up to say there are a couple of skin cases or orthopedic cases where I'm probably like, well, that maybe wasn't my best work. And so I can completely understand that when vets are maybe not doing the best gold standard workup for these cases, just like an ear case or a skin case or something else, is that we can end up with pretty adverse behaviour outcomes. So I would support the idea that using medication as a first line in my hands is not something that happens for me personally, but I appreciate it's not everyone's experience.
So, Michelle, what's prompted you to go further with behaviour training? Like, what's your interest in it, and what made you go? What prompted you to go further? And what are the courses? Because you just mentioned that you got the new qualification. So, what are the courses that vets can do out there to better educate themselves with regards to behaviour?
Yeah, absolutely. So I actually started my education journey in doing a science degree, and my undergraduate was in animal welfare and behaviour. So even before I was in vet school, I had a strong interest. I grew up working and training horses, and I got my border collie who's just turned 14. So I've had him since a youngster, and he was sort of a vessel through which I really honed and sharpened my training and behaviour skills. But so, yeah, I did my undergraduate in animal welfare and behaviour and learnt a heap about that. And so when I moved through vet school, which is a postgraduate degree, so an additional 4 years on top of that, I always knew that my focus wanted to be on behaviour. And unfortunately in vet school, we get limited time and lectures on pretty much everything, but behaviour was one where we didn't have a lot of scope to learn a heap. So when it came time for me to choose my rotations, I focused an additional 6 weeks, I think, of something around that, on doing my placements with behaviour specialists, both here in Sydney and here in Melbourne. And then I went out and worked as a GP vet for a long time, and during that period, I definitely did some small education courses on behaviour. But the two major courses that I've done is one through Sydney Uni, through the Centre for Veterinary Education, which is a year-long behaviour course, which is a distance education course, which covered a huge amount of topics, and I had access to a heap of specialists, which was fantastic. And then based on that education, last year I sat my memberships, which is an additional level of qualification, which allows, I guess, a recognition of a more specialised understanding of a field. And we have special memberships in all sorts of areas, like dermatology and medicine and feline medicine, all sorts of things. So as of last year, I've received my memberships in veterinary behavioural medicine, which is really exciting for me.
Congratulations. It's fantastic.
Thank you. Yep, got to add a heap of letters after my name, so it made me feel very special.
It's always a good thing. Now, for those playing at home, Michelle, can you, I suppose, give us a little bit of an idea of the different types of medications the more popular ones that are that you would prescribe? And I remember doing I think it was over lockdown, you did a Zoom session one evening, and it was really interesting because you were talking about the combinations of medications and the long acting and the short acting, and then you sort of give it a 4-week window to see how the dog reacts, and then you'll tweak things. So I found that really, really interesting. So are you can you give us a sort of rundown as to what's out there what's
Absolutely.
popular, what works, what doesn't in your, what you found that works and doesn't in your experience?
It's a really great question, and I might preface this with, I guess, the process by which I kind of look at prescribing medication. So I think for all of the dogs that I see that come to me, almost all of them are experiencing behavior challenges, but not all of them are experiencing mental health disorders. And I think for me, the first step before I'm thinking about a medication plan is to identify, Steve mentioned some of these dogs like might have an underlying health condition. Some may really have a lack of training or a sudden change in their environment that's made behavior different for the dog. And I guess I take very seriously my role is to be able to tease out to the best of my ability, and it's not always possible to tease out completely, which dogs are experiencing a mental health condition and which dogs are really experiencing something that is going to be adjusted by training. And I should say that even many severe mental health conditions are absolutely benefited by training and behavior modification. But there are many mental health conditions which we will really struggle to get a good emotional outcome, relief of symptoms and suffering, I guess, for the individual. And so before I think about a medicine plan, first of all, I have to come to the best of my abilities to a diagnosis and describe what's going on for that animal, understand the motivation, and then think about sort of, I guess, the internal workings of that dog that have led it to the point where it is, and understanding how I can adjust internal states. We know that external environment has a big impact on behavior, and so does internal environment. So my role is to kind of think about that and see is there a chemical way that I can adjust that. And in answer to your question, do some medications work and some don't? Oh, it's a loaded question. But I often find that it's a very specific individual response to treatments. And I often tell my clients the textbook makes suggestions of what we should consider, but your dog decides what's right for them. And you have the best knowledge of your dog. So it is really helpful for me to receive insight from trainers and also my clients about what's happening for their dog.
Dr. Michelle, just kind of aligned with that, because it's great to hear that you're looking through so many different lenses and from so many different angles. Is it your experience that you get many dog owners coming to you for the behavioural side of things when dogs are going through the early stages of that adolescent period and they don't necessarily understand how things can change in adolescence and they assume that there's some big behaviour issue? Do you see much of that?
It's a really good question. And I think that by the nature of my service that I provide, I see a little bit less of the kind of minor hiccups on the road for people, because usually by the time people are seeing me, there's something pretty significant. But in my general practice, Jacqui, absolutely all the time. And I'm really conscious to, I don't want to downplay what people are experiencing, because for many people, myself included, I have a 3-year-old Malinois, and I can tell you 3 is a dream. 9 months to 1 year was pretty challenging. And, I always tell people, yeah, absolutely. And I always tell people, if this is my literal job and I'm a qualified professional in this, and this is hard for me, of course it's going to be hard for you. So I think the first thing is I'm really conscious of, I guess, providing information to folks about what the different development stages are in dogs. And we've got, we move from this socialization to a juvenile period. There's often a little fear period around there, which is totally developmentally normal, appropriate, and adaptive to the dog. And I just want to pick up that term adaptive, because basically my job is to work out broadly for dogs what's adaptive and what's maladaptive, what's actually helping you and what's not helping you. But then again, less studied is this fear period around the adolescent period, somewhere between 7 to 9 months. And these things can be a hiccup. Now, interestingly, on your point that you make, Jacqui, sometimes conversely, I occasionally receive a client that's been told, hey, you should expect a fear period. And the things that client has tolerated because they've been told, no, that's normal. And the dog is actually going through a really severe kind of on a trajectory that's becoming very severe is also a challenge. So I guess I am very open to the idea that for an individual dog that there will be wobbles around that period. And I think that educating people about what are the realms of things that they might expect I always tell folks, like, if you take your dog out around this time period and suddenly it's got a real significant phobia of every rubbish bin, I'm like, let's just regroup and see where that's at in a month. I would be very slow to intervene in that personally, but it can feel scary to be in that as a handler for your own dog. I completely recognize that.
Especially when you got people saying that their dogs are destructive, they're barking, they're digging, they're whatever, and most of the time that these dogs are adolescent dogs, and they're bored and they're frustrated, and unfortunately some owners will rather than seeking the trainer first, they'll seek the vet first, and then, as Steve mentioned, there are some vets out there that won't even, they don't understand behaviour, they don't understand adolescent behaviour, and will be quick to medicate the dog because it's being a 7-8 month old teenager, which is it can be a little bit disheartening when that happens.
The question I've got there, can I just ask a quick question, Michelle? You've said whether the dog has got a mental health problem, whether or not it's not related to mental health. How do you determine, in your opinion, what is an example of each?
Yeah, it's a really good question, Stephen. It's often quite a fluid assessment. I think often what we might expect in, say, someone that owns a working dog, we have a very different set of behaviors that we expect to see in that dog versus someone with a pet dog. And sometimes the term that I use as well is neurotypical or neuroatypical, because I think it's really important that pretty much any behavior that a dog throws us is not inherently inappropriate, with a few exceptions. So I guess there are a couple of behaviors that jump out at me as being almost always maladaptive, i.e. they cause injury or danger to the dog, and often representative of a mental health issue, and probably most of the repetitive disorders, so light chasing, tail chasing, or tail grabbing and sort of injury to the body. I guess whenever I see that on an admission sheet, I am thinking more promptly about the role of a mental health disorder than I am with a dog that maybe has on leash, to maybe use some examples that, Jacqui's alluded to, like a 9-month-old dog that suddenly developed aggression on leash. I may be quite slow probably to consider that inherently a mental health disorder. But I think one of the major things is that I think it's very, very difficult, and you probably would all attest to this, is to make a firm, concrete assessment of a dog off one visit. And often we need some time. And I think for dogs in this very rapid development phase is that we often, the benefit of seeing what maturity looks like in a month or two can give us an indication about whether the things that we're doing are having an impact on the dog. The other thing that often gives me a clue about whether some of the dog's behavior may be neuroatypical is response to training. So if we have a dog that folks are doing some great coaching and they're working with a really awesome trainer that's understanding the issues that are at play, when that kind of isn't just sticking and the dog is not improving, of course I'll assess the training and see if there's anything I can add to, but sometimes it is more of a neuroatypical process in the brain that's preventing that stuff from sticking.
Yeah, look, I agree. The other thing I was going to say is that if someone comes along and says, look, my dog is displaying on-leash aggression because I think it's entering a fear period, not knowing what the dog was like before that period makes it tricky, because potentially the fear period may have just escalated this over threshold, and now what's happening is we're seeing some behaviour, whereas this dog could have been hesitant, avoidant, nervous, or concerned about the approach of other animals before, but it just wasn't enough to be able to motivate the dog to actually take any action.
Yeah, I totally agree. And I think it's why it's so important understanding motivation is essential, because let's say I was determined to use medication for a dog for this issue, and it's a bit of a fabricated circumstance, but the medications that I use for a timid, fearful, withdrawn dog that's using aggression as a last resort to try and stay safe is very different from that I might use to a very frustrated and adrenalized dog that's maybe had, often in my case, unfortunately, 6 months of rehearsing, talking to every dog that they want on leash, and then suddenly the rules have changed, and that dog is very frustrated. So to me, it's really essential that we try and understand the motivation, and history collection for both of our industries is so important to understand. Try and pick out where this behavior has come from. In the tapestry of the dog we see is lots of these threads that we often need to follow back a little.
Yeah, I agree with that 100%.
how can trainers better understand what behaviours really can be assisted by the way of integration with medication?
It's a tough question to answer, but I think there's a few things that always stop and make me pause when I'm thinking about whether this might be a veterinary mental health or physical health spin versus a more training based problem. The first thing I would say is that for many dogs that are experiencing very generalized issues, that medication is sometimes needed to really be able to get a foot in the door to develop a communication plan. So I'll often have a dog come to me that's got problems with separation, aggression towards visitors, problems with on leash, maybe noise sensitivity. And when I start to see those things stack up, it's not that I can't start a behavior modification plan, but often the other problems prevent you from easily addressing problem A. So, for instance, for me, a big part of my treatment plans is often providing dogs exercise. And with lots of people living in apartments or only having small courtyards, is the reality a lot of dogs need to get out of the house. And sometimes their behavior or mental health issues actually prohibit that. And so sometimes when I realize that the only way we're really going to be able to provide this dog the treatment that it needs to get out and about, when we have a big litany of other issues going on, is that can prompt me to consider the role of medication. So I would say to any trainers listening out here, when you receive a client and their dog that has a really big list of behavior issues, file it in the back of your mind, because often the more generalized these things are, they can be suggestive of an undercurrent of generalized anxiety. One of the other major conditions that I often receive from trainers, which can be really tough, is noise sensitivities and phobias, because it is really hard to counter condition and desensitize dogs to experiences that we can't control. For most trainers, when they're looking at a desensitization or counter conditioning plan, they're looking to create the stimulus and play with the distance, duration, difficulty, allowing the dog to experience it in a way that they can manage it. And often when we have dogs that either have really significant reactions to things, so phobic reactions where the dog is so adrenalized that they're not going to recall any salient information, is that can often be a better candidate for medication. And the other thing is sometimes the opposite of that, where the dog is so sensitive to multiple stimuli, again, that it's almost impossible to even work out where to start with the treatment plan. Medications can come a little bit more to forefront for me. But I think the biggest thing is I would say it is very rare for me to find a case where I think a dog should have come straight to me for behavior medicine intervention. I would say for anyone that's been working with a client for a period where they feel like they might have expected to see some improvement and they haven't, that sometimes is enough to just start floating that idea internally for yourself about whether maybe there's something a bit more unusual going on for that dog that may benefit from some form of medical intervention.
And of course, genetics plays a big part too, Michelle, doesn't it? Like it's sometimes you've got a dog that's just genetically unsound, that the no amount of training is going to make it significantly better. And it does require medications because you are working with raw genetics, unfortunately.
It's a good point. And I think as trainers, we're often thinking about the role of environment, of learning, and genetics. We're kind of taught, hey, these are the three things that affect behavior. And it would be so nice if they were all 33.3% of the issue that's happening. But you're right, for some dogs, there can be genetic issues that really come to the forefront, particular lines of dogs. So rather than breeds of dogs, it's particular lines of dog that we need to be aware of that can certainly have behaviours that are clearly heritable. And in some behaviour conditions, so let's take tail spinning in bull terriers, we can actually find that genetic sequence and trace it through generations. And it may be in the future that we can actually find similar genetic locuses or loci, areas that we can trace other issues. So, noise sensitivity or types of aggression. In the future, we really may be able to better quantify the genetic component. But just going back to what Jacqui was mentioning before about dogs in a adolescent fear period, genetic potential of the dog really helps me to try to provide people a bit of a prognosis about what their experiencing is. And it sounds like Jacqui and I may have had a very similar experience with having a relatively high drive, and both Trish and Steve, I suspect the same, having these, very powerful dogs that have come from a very solid line of genetics, and we can feel relatively confident that this dog's genetics is sound, but we all still go through those wobbles. It's a bit easier for folks around that very turbulent period to feel confident that things are going to settle nicely when they have insight into the dog's genetics. So one of the major questions I ask my clients about their dogs is, did you meet the parents? Recognizing that genetics isn't maths. Parents don't equal puppies, but it gives us insight. And are they in contact with any of the other litter mates? Because sometimes we end up seeing that this issue affects other relations of the dog, and that can give us an insight into genetic components. The other thing, recognizing, there's 1,000 things that I need to recognize, which is genetic aberrations occur, and sometimes weird stuff can happen that we don't understand, and there can still be a strong odd genetic mutation or component to a behavior that's not heritable, i.e. not passed on through the generations.
I love that.
Also, I guess, the matter of, and I'm kind of curious as to in vet education how much, even in your behaviour studies, you go into the breed characteristic type behaviours. I mean, you have a Malinois, and obviously everybody here knows Malinois really well. I know when my Mallie went through started her adolescent period and went through a bit of a fear period, I really saw that suspicion of new people get quite intense for a little while. And I think if I didn't understand that can be a Malinois thing in general, that you get that, initial suspiciousness, I would have worried that she had a human aggression issue. So is that, obviously that's something that you would be weighing up as well, like, adolescent periods can switch on some of those breed characteristics, like you see it in border collies and kelpies and stuff as well. But are vets focusing on that very much? Do you go deep into breed characteristic type behaviour?
I would say that broadly, the interesting thing about a veterinary undergraduate or postgraduate degree is that, I mean, maybe this is just an insight into my level of skill and education, but I came out feeling like a newborn foal from my veterinary degree on these big spindly legs with all this knowledge, but kind of not really knowing where to place stuff. And I think, like any trade, and I know veterinary medicine isn't inherently a trade, but a bit like trainers, they might come out of NDTF and have this qualification or Delta or whatever they may experience, but putting it into practice and honing knowledge and finding a knowledge base outside the curriculum is really important. So I would say broadly, we learn a lot about breed predispositions for medical issues, but I don't really think that the behavior stuff was probably touched on. But that's, I think, more of a merit that broadly behavior was a narrow subject in my undergraduate degree. And I think the real challenge is that even vets and lay people and even trainers, sometimes we make very unhelpful characterizations about breed, where really, I think I love the way that you're explaining this type, which is, hey, we've bred certain breeds to be more likely to behave a certain way, but we can't attribute behavior inherently to breed. So to me, I think that, yes, I think, I think a lot of vets are probably not super keen to see Malinois. I love them. Please send me all of your Malinois. But, I recognize that they're not really a pet dog. And so I think a lot of vets would feel quite out of their depth with them. But it is an area where I think that some vets become very skilled. But I guess if it's not an area of interest for an individual vet, it could be really hard to navigate that. And I think I find it hard at the best of times to provide solid behavior advice in a 15-minute vaccination. And I can appreciate that for the average person that's presenting a 9-month-old dog with significant behavior changes, attributing it to breed might be really hard. And I can imagine a lot of dogs probably end up slipping a little bit through the cracks there of not having
there must be quite a bit of pressure on vets. For a lot of owners and laymen would assume that you know about everything. Like, you know about different breeds, about training,
Of course you do. You have to.
You know everything. Because, I mean, a lot of the times we have discussions online with people. It's an argument will be, well, my sister's brother's a vet. Do you know what I mean? And
if it's any consolation,
Jacqui, a lot of pressure on you.
I still get people turning up to a consult and saying, well, my sister's brother's a vet, and they said opposite of you. So the good news is those people seem to be happy to trot that out wherever. But yeah, look, I agree. And I'm really upfront with people. I've been graduated since 2016 and I'm very comfortable in telling people I don't know and I can't know everything. And I'm really happy to tell folks when things are out of my wheelhouse. And that's why I still love working as a GP vet. People often ask me, will you ever go do straight behaviour? And I say, I think my brain will explode. I love working in the general practice. I love keeping my mind open and active to the kind of, I mean, I shouldn't say real world, but I guess the broad world of normal, I guess, experiences of the average person, but also kind of the broad general health stuff. But you're right. Like, I think there is a lot of expectation, and I'm not convinced that I think most vets are very type A people that feel very anxious about what they really don't know. But you're right. It is a really trusted profession, and it can be difficult because I often find something I mention in passing, someone might really take that to heart and kind of run with it in a way that I really didn't intend. So I agree. We have a great responsibility to be upfront with the things that we do and don't know. But I also know that for most vets, the reason they're in this industry is certainly not for the pay, certainly not for the glamorous hours or the, illustrious outfits. I think I wear scrubs and runners even on the weekends half the time. But it is because they love animals and they love to help them. And I know everyone's goals and focuses might be slightly different, but I think everyone working in this industry ultimately has a passion and a love for animals in their chosen career path.
Michelle, just going back to the medication, is it true that some breeds react differently to medications? And I'll just give an example. I've got a very good friend of mine who does rescue groups or does rescue, and there is the belief that sometimes certain medications don't work with certain breeds of dogs. So, like Clomicalm doesn't work on Staffies or Staffords in general. Is that correct? Is that true? Is it some breeds the medication doesn't work as well on them as others due to their makeup or due to their
with Aussie Shepherds? So that's an interesting question.
Yeah, so I guess let me tell you what the science can kind of describe for us. There are certainly some dogs that have genetic mutations that make their processing more difficult. And Jacqui's alluded to Aussie Shepherds, which are often carriers of the MDR1, which is a certain genetic mutation, which means their processing of certain medicines, which tend to be associated around anesthesia, chemotherapy, and a couple of other sort of gut medications, is that their processing isn't 100%. Now, first of all, I think broadly when folks are breeding, they should be testing their breeding dogs for MDR1 and breeding clear by parentage. But the test is inexpensive for the MDR1 gene, and it's just a mouth swab. So anytime I see a new puppy consult, one of the first things I mention to someone that might have a Toller, a rough coat, a collie, border collie, any of these dogs or Aussie Shepherd, more predisposed to MDR1 is that we consider genetic testing. And those dogs absolutely have altered metabolization of these genes that can actually be quite dangerous for them. So it's very valuable for us to know. In regards to, I guess, more perhaps people's lived experiences, I certainly think that with behavior medications, I would say for someone that's working in rescue, they often develop preferences because they deal with a huge number of dogs that they come through their doors, and they may feel that in their experience one medication's been more effective than another. I don't think there is strong evidence to say that, for instance, the medication you mentioned, Clomicalm, is ineffective in Staffords. However, I would say if someone came to me and said, I perceive this, I don't really feel a strong need just to prove them wrong or right or whatever and go down that route, because usually when I'm considering a medication plan, in my hands, it's not an order, it's a conversation that we have and a discussion that we have. And I often find, Trish, that for people that are coming to see me, often they have lived experience with mental health medications themselves. And someone might say to me, look, I took the medication you're suggesting and I had a really terrible experience. 9 times out of 10, I will usually say, hey, like, there are maybe some other options we consider. Would you be open to that? And if we can navigate around that rather than having to go through that, I think that's just a nicer experience for everybody. So in answer to your question, I'm not convinced there's strong evidence for it, but just because it's not in an evidence base, it doesn't mean that it's not someone's experience.
That's good. Yeah, I suppose talking to a few people, because I do some work with rescue groups, and they do, like you said, they obviously have their preference or they have their belief systems, and it's just interesting to hear that. And I once heard, I don't know, I was listening to a podcast with Dr. Jean Dodds, and she was talking about how black Labrador, so there's a certain gene in a black Labrador that means that the dog actually doesn't metabolize vaccinations. So the black Labradors go throughout their lives being not covered by any of their vaccinations. I don't know how true that is, but that's what she stated in one of her podcasts, and I found that absolutely amazing. I thought, wow, I wonder if anyone's researched into this because it was one hell of a claim to make.
Well, we've got Labradors, and some of ours are black, of course, and we focus on TETA testing after their initial vaccinations and through life, unless they need vaccinations. And pretty much a very large percentage of our dogs have very good TETA results the rest of their life, so they don't spend a lot of time being vaccinated.
I love that, Steve, because I was about to make the comment that I think a single titer test or a TETA test would be able to potentially prove or disprove that. Obviously, I don't want to speak about someone's experiments or studies that I'm not aware of, but I think Steve has made a really good point here, which is he has titer test evidence to say that the vaccinations that his dogs received have been successful. So
that's good.
How many labs do you have, Steve?
We've bred more than 50.
Okay, so I think we've got enough for a case study. If we want to go and we want to get together and put a paper together, I think we'll meet at Steve's place and get cracking.
Well, there you go. And I must say, I was driving, I was listening to it while I was driving, and I almost stopped the car going, what is this? Anyway, moving on. So just going back to, I suppose, the trainer situation and the vet situation. As you know, you're sort of one of the few vets that I know that provides feedback to the trainers and information back to the trainers. Do you think that, if a trainer has referred a client to a vet, is it that vet's, I suppose, responsibility or due diligence to communicate with the trainer or the referring trainer what was discussed with the client and what medication, if any, has the dog been put on, etc., in a training plan or working together? I think that's really important, but what are your thoughts on that? I know you do it, but do you think that should be the norm, that should be the practice throughout?
Yeah, I think it's a really good question. And I think it's helpful to maybe set the scene that there are lots of different levels of vets that work in behaviour. And I'm lucky that I guess I still have a foot in the general practice camp as well as the more focused behavioural clinic camp. So I think for lots of folks that are working in a GP setting, I think if a dog came to see me that was referred by a trainer to my GP clinic for a short 15 or 30-minute appointment that included some behaviour stuff, I'll be the first to put my hand up and say I probably won't be able to include referral material to send to someone in that short period, because it's often 30 minutes is just enough time to do a physical exam, maybe collect some bloods or do some testing and discuss a few things, but it's often not enough time for a write-up. But when I was creating my behaviour service, I really knew that I wanted to have time for that. So as I've moved from being a general practitioner with an interest in behaviour to a vet with additional qualifications in behaviour, I've been able to build that into the way that I consult. So after every consult, I have a certain period for note writing where I email the client written notes of what we've discussed and plans, and I sometimes send a separate email to the trainer, sometimes send a CC. But for me, that relationship is really important. I know there are a lot of other behaviour vets, or there are 3 levels of additional veterinary behaviour qualifications. The level that I have is memberships. Above this, we have fellowships, and then at the very top, we have specialists. I think the more that folks get up into the top end of their qualifications is the number of trainers I think that they work with becomes much smaller, and often they pair with one trainer that maybe works in their building or they have a strong relationship with. And so I think that for many trainers, I always encourage them, if you're wanting to work with a vet in behaviour, it's not wrong to try and seek out one of those more specialised vets to build a relationship with. But I often find that the best way to build a relationship is with someone that's sort of more at my level, which I still have a large network of people that I work with. And general practitioners, I think, are great people to build relationships with. But in answer to your question, which is really about, should trainers be involved in the sharing of information? First of all, I always ask my clients. I've never had anyone say no, but theoretically, if they said no, I'd be cool with that. But yeah, I think there's a lot to be gained. And sometimes I'll make a quick phone call to someone if it's faster, drop them a voice note. I always actually invite trainers if they'd like to attend an appointment with me, with their client. If their client's cool with that, so am I. So personally, I have a very open door policy. But yeah, I think I found it very valuable. And if there's any vets listening that are thinking about this, I would encourage you to dip your toe in and give it a try.
So rare. Dr. Michelle, can I ask you, are there best practice guidelines for obviously behaviour vets, but general vets, in terms of combining like medication and behaviour mod plans? Like my understanding that it's like behaviour mod training should always be recommended in conjunction with medication. Are there actually guidelines that break that down at all?
That's a great question, and I've literally just Googled it because the answer is I'm not sure. Now, there is a group called the World's Small Animal Veterinary Association, WSAVA, and they sort of set out codes of conduct broadly, but I'd be surprised if they had a behaviour one, but I don't know. You might need to leave me on notice with that.
That's interesting.
Yes, but, we have all sorts of minimum guidelines for anaesthesia or I use a lot of guidelines because I now manage a larger team. When I first started as a general practitioner, it was me and one other vet, and now I manage a larger team. And so to have us all on the same page, I have guidelines for antibiotic use and the way that we treat ear infections or, the way we manage urinary stones is we try to create a very systematic look. My initial thought is behavior doesn't follow the textbook often, and it doesn't, present the same in everybody. So I think it would be challenging. However, your question, which is about should behavior modification, so that's alteration of behavior and, changing of the environment the dog is in, be paired with medications? Always. I can't think of an exclusion. Maybe some very severe, like neurological, like I have a few dogs that have components of potentially brain disorders, very complex genetic disease, chronic spinal issues, etc., that we might go, we need to be very hands off with this particular dog. But I would say that stuff is very rare. And in fact, if you have a look on most we only have one really registered medication in Australia, which is Clomicalm or Clomav, as Trish mentioned before. If you look on the bottle, the label claim in Australia is for the treatment of a few behavioural in aid of treatment of some behavioural disorders that are listed on there. So it's not to resolve it, it's to aid in it, and what it is aiding is behaviour modification.
It's still true the case that some, and I don't mean this in a negative way, this is just my ex-farmer rep being curious.
Yeah.
Is it true that some of the medications being used for mental illness in dogs are technically off-label use?
Oh, yes, almost all of them. So, for instance, Steve
so.
mentioned fluoxetine potentially at the start of this. Fluoxetine is off-label, which means we don't have a registered product. In America, they do. I suspect it probably failed in Australia in part because we have wonderful universal healthcare, which means that Australia sets a maximum private price for certain medications. So even folks without Medicare, visitors to our country, etc., still have to have access to life-saving medications. So because
that's not necessarily a bad thing, is it? Because I know in pharmaceuticals sometimes something remains off-label merely just because the company doesn't think it's worth those millions and millions of dollars to do that research to get an indication specific, even though we know that it might be effective in those off-label cases.
Absolutely right, Jacqui. So off-label doesn't mean it's not got evidence or studies behind it or that it's not safe. It means that we haven't made a pet version. So for most of the medications that we use, they are off-label, and it's really important to me that my clients feel well informed about that. There are always studies, multiple studies, and often decades of studies. In the case of older medications like fluoxetine, is that there's often decades of information saying, hey, here is lots of evidence that it's helpful, but we don't have a pet-specific version. The benefit of an on-label medication is that I can tell my client that there is enough information to say that this is helpful for the exact disorder that we're treating your dog for. So noise sensitivity, separation-related behaviours, etc. So it's lovely to have things on label, but for most medications that we use, and that's not exclusive to behaviour, it's a bit more prominent in behaviour, I guess. Behavioural medicine is a a more emerging kind of area, I guess, over the last, say, 50 years compared to some of the other specialties. But it's not unique to behaviour. It definitely can exist in many areas. So, for instance, like many of the antibiotics we use have an off-label counterpart from the human pharmacy.
And what are the side effects to some of these medications, Michelle, that you've seen in the past? General side effects or severe side effects that may occur?
Yeah, really good question. And the good news is, touch wood, severe side effects are very rare, and I can't think easily of any significant ones that I've luckily had to work through with a client. But I think one of the most important things about in working in veterinary behavioural medicine is to make sure that whoever is administering these medications understands what side effects they might need to expect and be prepared for, and how to navigate them. So for many of the behaviour medicines that I might use, many of them act on serotonin. And most people think, yeah, serotonin, that makes you feel happy. It actually does a heap of other stuff. So it's implicated in memory, learning, aggression, sleep and wake, emotions. But one of the major areas that it's relevant for us is actually in digestion. So a lot of the long-term behavioural medications that we might use in dogs often in the short term have an impact on digestion. Some dogs can feel a bit nauseous, and that often means that they're a bit off their regular food, but they might still be happy to work for special treats or things like that. It would be rare for me to see vomiting or diarrhea. I think that would be a point where I would be questioning about how this is working. But some dogs can also feel a little bit lethargic for 1 to 2 weeks. And it's tough because a lot of the dogs that I might be using this medication on might be really experiencing some hyperarousal and excessive activity that's actually uncomfortable. And often it can feel a little bit scary if you've lived with a dog their whole life where they've always been constantly patrolling and busy, and suddenly see them sleeping. So it's really important to me that we set the expectation. But most of these side effects in many of the long-acting medications that I use, so daily medicines, are transient. The way that the body processes or responds to changes in levels of serotonin has 2 phases. And in the initial phase, we can sometimes see flatness and lethargy and issues with digestion. But in the long-term phase, when the medication reaches a steady state and the dog normalizes or reacquaints themselves with a new serotonin level, is that those side effects usually disappear. So for most dogs in the long term, what I'm aiming for is really not to see many side effects. Some of the other short-acting medications that we use might work on different...
Can I just interrupt you, Michelle?
Yeah, please.
Do you think that that's all also dosage dependent? Because we see dogs coming in where the owner has gone to the vet and the vet's prescribed fluoxetine and the magic hasn't happened, and so the dosage gets increased and increased until, if you had a look at the level per kilo that would be ideal, is just the dog getting on 4 or 5 times that, and it's losing weight because it has no appetite and things. We see it, quite a lot of that as well.
Yeah, so I would say that's definitely not normal, and, dosing 4 times above the normal range doesn't sound safe. Fluoxetine has a very narrow dose range. So it definitely sounds unusual, and in my hands, that's not something that I would be happy to work with. I think it is really important to me that if we trial a medication, to fully explore the range of the medication and not give up too early, because sometimes we can miss some really helpful impact of the medication. But I think what you're describing to me sounds like it's probably not great behavioural medicine, and I think most veterinary behaviourists would probably agree with that.
I think what you said before was really important is that when you're talking about Clomab or Clomicum is that it's not a solution, right? It's just it's to assist. Whereas I guess if someone only provides medication and they don't find a solution, I guess some logic is to just keep giving them more until you find your solution, because you're expecting a solution rather than some assistance.
Yeah, and I think it's why it's important when I have a client that comes to see me for a behaviour consultation, we have a long discussion about what success with medications looks like. And we talk about seeing reductions in the intensity, frequency, or duration of behaviour and improved recovery. But rather than just telling them that, I try to put a metric on it. So I say, okay, look, we're dealing with behaviours around, let's say, on-leash aggression is a good one because it's easy with distance. So we look and see, cool, is the plan that we're implementing, so we might be teaching a strong alternate behaviour, we might be marking for the presence of the dog, and then we might be moving away. how is the dog engaging in that exercise? How is the intensity of behavior? Instead of getting to 10, do they get to 7? How is the duration? Do they stay heightened for a long period? How is the frequency? Are they continuing to seek out every dog they pass by? And then how is the recovery? How long after, this experience does it take them to cool down? And I actually ask my clients to keep a diary, but I recognize that I'm working with uniquely very motivated people that often do a lot of work that I hope I would be able to be the kind of client that I have, but some of the people I work with are outstanding. I also recognize that in the GP setting that often I'm not able to have these deep conversations. And the other thing I would say sometimes is that folks sometimes don't come for revisits, and it can be really hard when you're not aware that the dog is experiencing these adverse effects. Because sometimes the things that you've described, Steve, while it wouldn't be common, it could happen at a low dose. And sometimes I get feedback that from a trainer that this dog's like looking really kind of pretty crappy, and I actually have no idea because they haven't come back for a revisit. So it can be really tough. And I think you've touched on a nice point here, which is, communication about what to expect, and that these things aren't normal, is important to empower the clients that we work with to, advocate for their dog's best health.
If I can just make a comment, in my experience, a person who's speaking like you about duration, measuring intensity, distance, and all those is extremely rare. That's the stuff that we talk about, but we don't get that's giving that information. So I would definitely refer people to you.
That's very kind feedback, Steve. I would love to receive any of your clients, because it is a bit tricky for me to work interstate, but I think when I have a trainer that I'm working with, I'm not qualified to dispense medications interstate, but I absolutely do work with some wonderful trainers and clients that I can make recommendations to. And I suspect there are a few more people like me out and about, but I think it can be hard to build a personal relationship with vets at times, because we tend to be very busy creatures, which is tough. But I will bet my hat that there are more people just like me somewhere around the country. And I hope that anyone listening that's thinking about building a relationship, you never know how open your GP vet is to learning this stuff. I didn't come out of vet school knowing half the stuff that I know. I've accrued knowledge throughout my career, but, seeking education. And I think for any trainers looking to build a relationship with a vet, start now. And, the folks that had faith in me as a humble little new grad, hopefully are reaping some of those rewards by having access to the education that I gain, and I have access to the education that they gain. So it can be a really fantastic relationship.
Our own personal vet is really, really good, and we work with her a lot. And we have a range of professionals that we refer to, from chiropractors, osteos, skin specialists, and all sorts of things, that if dogs are coming to see us with any issues, we have great people we can refer to. I'm just talking about clients that before coming to us have been to see any level of vet, ended up on some behavioural medicine, and are missing that crucial information that you've said. These are the metrics that I measure performance of the medication and effectiveness with. They don't know what they're looking for. They're looking for it's completely solved the problem, or it's not working at all. I go, it's not a switch that switches off behaviour. It's just going to assist you.
Yeah, I think I agree with you.
And I think we're fairly lucky here in Victoria that we have Michelle. But maybe, Michelle, if you would be, obviously we'd like to refer people to you. And if people are coming from interstate or they're contacting you from other states, maybe you'd be able to provide them with details of vets that they could liaise with in their particular state that you could potentially recommend. Is that something that you could do?
Yeah, I absolutely have a couple of lovely people that particularly I met during my distance education course around the country, and super open to that. You'd be very welcome to.
Where can the good folks here of the Professional Dog Trainers Australia find you, Michelle? Like, what's the easiest way they can make contact with you?
Absolutely. You can find me on socials, and you can see me messing around with my Malinois and all my fun vet stuff on Instagram, and my Instagram is at Dr. Michelle Rassool. My name, I'm sure, will be spelt here somewhere in the show notes because it's a SSO. You can also find me online, and my website is www.drmichellerassool.com. If you Google me, I will probably show up pretty promptly, and I have a heap of resources, information on my website as well. I do consult from my behaviour space here in Northcote. I consult from a GP practice in Melbourne as well. So if folks are also looking for accessing a really I guess, holistic viewed general practice, particularly if you own a high working drive dog that doesn't perhaps fit the mold at a normal GP practice. You are super welcome to come and see me, because I love working with dedicated people that have really great understandings of their dog, because it makes my job a true joy, and it's really easy to work with motivated people.
That is fantastic, Michelle. Thank you. Just before we wrap it up, guys, I think we're on time now. So we'd just like to thank Dr. Michelle Rassool for joining us today in this podcast, Integrations Between Medicine and Training. And of course, if you've got any questions on anything you've listened to today, or you have any other questions for Dr. Michelle, perhaps you can email us info@dogtrainersaustralia.org, or you can certainly ask that in the post notes on our Facebook page, and we will reach out to Michelle and get some answers for you. Any last questions from Jacqui or Steve for Michelle before we wrap it up?
Thank you so much, Dr. Michelle. It was very, very interesting.
You can also find us on our Facebook, our PDTA members page. We'll have some information there for you. So thank you very much, Michelle, for joining us. Thanks, Jacqui and Steve. My name is Trish, and we shall catch you at the next one.